Hi, everyone. Dr. Maria Sampoulos here. Thank you for joining Corporate Optometry on Facebook Live. I have the pleasure of the president of Nulids, Robert Foster, with us tonight. Thank you, Robert, for taking the time.
Thank you, Dr. Sampoulos. It is indeed an honor to speak with you.
Thank you. I wanted to introduce the group to Nulids because I know it's new. It's a lot of traction in the industry. A lot of doctors using it. I wanted just to give doctors intro to it and just to get some information because it's so easy to implement it in their practice.
We've been truly fortunate. I don't know if I've told you this before, but in January of this year, we went over 1 million successful treatments. So
wow.
we're doing very well, and it's because of folks like you and your listeners who are really embracing Nulids and recognizing that a home treatment component to their dry eye treatment is terribly important.
Yeah. How did you get started with Nulids?
Well, after I left TopCon, I was looking at several different projects, and one of them, the Dr. John Olkowski, who is a cornea specialist practicing in Honolulu, had this crazy little device for the home treatment of dry eye. And I sat down and talked to him about it, and I said, well, why is this necessary? And he just laughed and said, Rob, I can't tell you how many people that I've sent home with instructions to do warm compresses and lid scrubs. And they don't have time to do the warm compresses, and they either do the lid scrubs the wrong way or they irritate themselves, and they come back for their next visit in a year. And I asked them, what did you do with how are you doing with the lid scrubs? And the patients kind of look down and say, well, they're still sitting on my shelf in the bathroom. So the compliance issues for dry eye and the wide suffering with dry eye, I mean, close to 40 million people in the US alone, really called for a device that actually is going to get used. And indeed, we just checked on the compliance factor. And as you know, compliance with things like Restasis and Xiidra are, after about 6 months, less than 10% fill rate. And right now, we're at 49% of the maximum compliance. So that's how we got started.
Oh, yeah, that's a lot of great information. How long has Nulids been available?
We started on the marketplace. We had a soft launch in May of 2018 at the American Optometric Association meeting. And then our hard launch, where we really made a lot of noise, was September 2018 at Vision Expo West.
All right, so it hasn't been out that long, and it's gotten a lot of traction. I mean, it's a lot of doctors use it; they love it. A lot of patients use it and increase compliance. I think that's this is kind of an easy way to implement it in their practice if doctors want to start dry eye and try to build their practice on dry eye. What are some indications of Nulids?
Yeah, the major indications are meibomian gland dysfunction and/or blepharitis, and I know that there's a very large crossover between the two of those things. Interestingly enough, we get just like we were talking before this, Dr. Sampoulos. We have doctors calling in on a weekly basis saying, hey, have you tried this on chalazion or hordeolum on rosacea patients? And of course, we were talking about the root of those things being in many cases Demodex. So really any condition that is related to the meibomian glands, related to Demodex, Nulids is actually proving itself pretty effective. So the answer to your question in terms of how it is registered with FDA is for the treatment of blepharitis and meibomian gland dysfunction caused dry eye.
Very good. The term mesh is being used more and more when I go to CE lectures, and it's related to Nulids. Can you tell me about that? Because I hear it in CE events and things like that, and I think our listeners should be informed on that as well.
Well, thank you. That's a great question. That's a lot of people just don't know what mesh is because it is a fairly new term. When I was talking with our medical advisory board last year, of course, CE courses, you're supposed to stay arm's length away from anything that is commercialized. So repeating the name Nulids, Nulids, Nulids over and over, we just didn't feel good about it. So I asked the medical advisory board to come up with an acronym for what Nulids really does. And what they came up with was mechanical eyelid stimulation and home hygiene. And that does a really nice job of encapsulating what Nulids does. It is the first and a unique mechanical device for use at home by patients, completely safe, by the way. And it both stimulates and cleans the eyelids, which of course reduces the inflammation causing factors such as biofilm and Demodex.
Yeah. So how does it work with like biofilm and patients using it at home? And is it like a learning curve? Is it easy for patients?
The learning curve is very fast. You talk about our patients that were on the published clinical trials were multi-center, and patients were basically shown one time in the office how to use the device. And then they took it home and used it. So quite literally what they do is they push the button on the device. Now, I've got bad sunlight here, but a white light has come on in it. And then the tip, a clean tip every day, is inserted into the aperture on the tip. It's placed against closed eyelids, and the best place to start is right there at the nasal, right there nasally, and then push the switch and slowly go back and forth across the eyelid. After 15 seconds, the instrument will automatically hesitate and then switch eyes. It's like that. Literally 2 cycles of what I'm doing right now, 2 cycles of 15 seconds each on each eye is a complete treatment for the day. And that's the mantra, is 1 minute a day. And then regarding the tip, then throw it away. And of course, the reason to throw it away is because all of those nasty little bugs, whether it's Staph aureus or Demodex or some combination of both of those things, end up in that tip. And if you leave it sitting on the counter in your nice warm bathroom overnight, those little bugs they're reproducing. And if you use it again the next day, well, you've just introduced a much larger colony of bacteria or parasites back onto the eyelids.
Yeah, I think that's important to tell our patients too, because I think some patients want to reuse things.
Oh, of course, everybody wants to make it as cheap as possible. I understand that completely. The great news is that our compliance at 49% is 4 or 5 times higher than the next home use product. So it actually is having an effect. And I think the reason that our compliance is only 49% is because some folks cheat and they reuse the tips. And what you can tell your patients when they ask you about reuse of tips is, that's fine, I'll be treating you for an eye infection soon.
What are some published clinical trials out there to support the safety of Nulids?
The best known was published in the Journal of Dry Eye in January of 2020. We call it Nulids 2. It has a very long name about mechanical device for the home treatment of dry eye symptoms due to MGD. I mean, the title takes up about the first paragraph. So we refer to it as Nulids 2. This was a multi-center study done both MD and OD. David Shansland, who used to be the director of cornea at the University of University of California in San Diego. John Coble, who ran education for the American Optometric Association, and John Olkowski. They had similar numbers of patients. I think the nice thing for your listeners to understand about it is they're smart enough to recognize that companies are very good at tuning populations inclusion, exclusion criteria, and methods in order to make things work out. I did not agree to sign on with the company until we had a well-conducted study that reflected what your colleagues are seeing in their patients. So that's why you'll see this protocol had very limited inclusion and exclusion criteria. As long as you had a speed score of 12 or an OSDI score of 25, you were included. And the only exclusion criteria were for patients who had a serious hand tremor. Obviously, they can't run it themselves. Patients with a history of herpes simplex keratitis, because we know that creates an anesthetic cornea, and patients who had had eye surgery 90 days prior. So it really should, and indeed what we hear back from your colleagues is that the results that we got in the clinical trial were the same results that patients and doctors are seeing today in their clinics. Probably the most notable 2 or 3 outcomes were that after 30 days, and it was a very short clinical trial, we found that we initially thought we'd have to do 90 days. The actual peak of the effectiveness curve was 2 weeks into the trial. 68% of patients said they noticed an improvement after just 1 week, and 94% right at the 2 standard deviations that had a positive effect from the trial, they said they noticed the change within 2 weeks. So we stopped the trial at 30 days, and at 30 days, tear film breakup time was up by 2/3 from, I think it was 4.8 seconds to 7.9 seconds. And the Miggles score, the meibomian glands yielding liquid secretion, the number of those glands that were open and yielding clear liquids went up by 82%. And patients, of course, reported that their OSDI scores had decreased by over 50%. So we were extremely pleased with the outcome.
Yeah, where does Nulids fit in dry eye disease, ocular surface disease treatment continuum, like in a practice?
That's evolved over. Yeah, that's a really good question, because the answer has evolved over time. Of course, we didn't know how effective it was going to be in the general population early on, so we suggested that Nulids at first would only be adjunctive therapy to those treatments that are being performed in the office. Cynthia Matosian was a big proponent of that. I just spoke with her last night and asked her whether or not she was now on board with positioning Nulids as a frontline therapy and a standalone therapy. And her answer was, as long as the patient is doing a combination of things, hydration, blink exercises, omega-3s, she's very comfortable beginning that patient on Nulids, and indeed is seeing very good results. So great question, Maria, Dr. Sapalis. It has changed sorry about that, getting too friendly on the phone. It has changed over time from an adjunctive therapy to a standalone therapy that also, of course, can be used adjunctively with anything else that your colleagues are doing in the office.
Yeah, a lot of doctors want to get into dry eye. They don't know how to get into dry eye. I think this is pretty easy to kind of get started. What do doctors need, like special diagnostic treatment, equipment, start dry eye service? Because I just started like dry eye clinic in Rhode Island, and I'm still learning, but it's great to try all these new things and see relief with patients.
It really is. And I think maybe the major message that I'd like for your audience to go home with tonight is you don't need a lot of specialized equipment or a lot of additional expertise in order to start a dry eye clinic. We all know that 86% of dry eye is related to blepharitis and meibomian gland dysfunction. And quite literally, the diagnostic process that has, again, the Medical Advisory Board came up with a 1-minute diagnostic process that is highly accurate. It quite literally is lid expression, right behind the slit lamp, where we express nasally, centrally, and temporally, and simply count the number of dots of clear meibum that have come to the surface. If you have less than about 20 dots, there's clear meibomian gland dropout. And ask 3 questions. Not if they use dry eye, artificial tears, but how often? How many times a day do you use artificial tears? Do your eyes feel tired, especially at the end of the day? And does your vision change or fluctuate throughout the day? The time it took me to express my glands and ask those questions is quite literally the time it takes to accurately diagnose meibomian gland dysfunction. So I hope that your audience understands that with the presence of something like Nulids, not having any specialized diagnostic or treatment equipment in their office, they can begin making the vast majority of their dry eye patients feel better right now.
Yeah. I've talked to some of my colleagues about this product, and some say that it might be something where it might work so well that we might lose patients from coming back for future treatments and follow-ups. What is some data on this? I mean, because in general, we want to have good effects for patients. We don't want to keep wanting to have patients come back if we don't solve the problem. Absolutely.
And, frankly speaking, based on the good results that we're getting with Nulids, we were a little concerned about that as well. So it was very painful to wait, but I told my marketing team, I said, we're going to wait until we have 1,000 patients that have been on Nulids for a full year. Because if you take these measurements very early on, say within 60 or 90 days, you get false readings because it's still new. It's there. People are still excited about it. So, okay, we waited, and we got 300 responses back. So 4 things that are of major importance came out of the patient surveys. The first thing is that we get 9 out of 10 in terms of effectiveness and satisfaction for treatment efficacy, the value of the product, and the convenience of the 1 minute per day treatment. And the thing that came out that is so important for doctors is that 94% of patients who were dispensed a Nulids device are still with their same doctor. Now compare that to what we know about the dry eye studies and the number of doctors that patients go to before they settle on a doctor. The studies show that a given patient with dry eye will go to 3.5 different doctors before deciding who to see. So without Nulids, you have about a 28% chance of retaining that patient in your practice. With Nulids, you have a 94% chance. And indeed, not only do the patients come back, but doctors who had taken their very expensive equipment like LipiFlow and kind of put it to the back because they were getting bad feedback from patients. After the first treatment, the patient was so happy because for at least 3 or 4 months, they were feeling great. And then the symptoms came back. Patient comes back into the office, and the doctor says, we need to do LipiFlow again. And of course, even at today's prices, about $600 per eye, not everyone can afford that. Now, all of a sudden, because the patient was dispensed Nulids and because of that high degree of satisfaction, the patient comes back to that same doctor and says, I'm feeling much better. Do you think I'd do even better if we did another LipiFlow? So it's actually buoying the use of the products that are already in the office.
Yeah, that's good. So it's in addition to the practice, and it's easy for doctors to get started.
Right.
I have in my practice, there's different models that doctors can use it. Some doctors like selling product in their practice, others don't. What is the advantage of something like this for a doctor that doesn't like to sell products to patients?
Sales is not something that everybody wants to do. And most doctors, they view selling as something that just is not in their lexicon. What they want to do is just the best thing for that patient. So we have 2 different programs for doctors who like to sell things from the practice. It's called office delivery. The doctor purchases the devices from us and resells them to the patient. They educate the patient, they register the patient on our website, and they're done with it. Now, the more popular of the 2 programs, and this started with COVID, because as you know, with COVID, dry eye patients were not supposed to come in and see their doctors. That was not considered an emergency. So we put together a program where the doctor with their known, what is it, the H04.12, the ICD-10 code for dry eye disease. Doctors are going through their patient records, and they're contacting those patients and saying, I want you to have Nulids, and I'll be putting you in touch with the company. One of their customer service managers will call you, educate you on the device, and should you decide to do so, you can purchase it directly from them. And of course, the doctor still gets paid when that's happened because the doctor is doing work. That's called the affiliate program, and the affiliate program has become much more popular, not only because there's no selling that goes on, but there's the office disruption that happens when you have to train somebody on something new, and all of a sudden your scribe is not with you anymore, and there's a backup in the front office because there's emergencies. That we take that off of your hands as well. And because that's what our customer solutions people do all day long, your patients are getting a true expert to support them.
Yeah, and it takes, time from away from your office, right? So you're not doing that. And also, exactly. A lot of offices now with COVID are still like short-staffed. Even my office still short-staffed. It's hard to get people to want to work. It's just right now it's just nuts. But something like this with COVID, when I thought of with the dry eye syndrome in Rhode Island, I said, well, this is easy to implement. It's not a big cost. It's not hard to train staff. And we have two options. We can sell it, or we can have this program for patients that might not want to, but want to maybe think about it and have an option to purchase. And we still make income off of it, even if we don't sell it, even through the affiliate program.
That's right. And something else, we've been very blessed with the success of this product. So if the patient comes back to you in a month and says, this just isn't working, and a small percentage will, 4 or 5%, we'll take it back and give the patient their money back. We don't want anything we do to reflect negatively on us or on you.
Yeah. That's great. That's great for doctors. It's kind of like no risk for the doctors, right?
That's right.
I mean, there's a lot of pressures, a lot of ways to kind of generate revenue. This is one great way, and with dry eye in general, what's the benefit financially from practices from Nulids?
Well, the affiliate program, it's $50 back to the practice. And then 20% of everything, all the tips, all the gel, anything else that is purchased through the lifetime of that patient, all that money comes right back into the practice. If you decide to do all that work of selling, educating, registering the patient yourself, we of course can't tell the practice what to charge, but the average practice makes about $100. So the decision that the practice needs to make is, number one, are we good at selling? Do we do this well? And number two, is it worth an additional $50 to spend that technician's time, the front office's time to register the patient in order to get the patient into the device? And again, most doctors are making the decision that having the $50 and having us do the work on the affiliate program is probably best. Yes, you can make a little bit of money on Nulids, and obviously that's not the primary reason. The primary reason is providing relief for your patients. But frankly speaking, the real financial equation and the real financial benefit of Nulids is that 94% of those dry eye patients staying in your practice and not going to your competition. The American Optometric Association says those patients are worth on average $300 a year. So not only are you getting some financial benefit from the Nulids system, you continue to take that $300 a year rather than having it go to that competition.
I did a lecture on medical model, and dry eye revenue can be $100K in your practice additional.
Oh yeah.
And without big significant equipment. We're talking about plugs, omega-3s, follow-ups. Some insurances will pay for anterior photos, and we're just talking about anterior photos with cameras, right? My phone. Mm-hmm. But even adding this is a substantial, right? Because they have to continue to use it. It has to continue to go. So something like this, in addition to warm compresses and sprays and things like that, is a great revenue, and it's easy. There's no big issue in your practice, right? And so if a doctor wants to get started, they can go baby steps, do the affiliate program. Once they kind of get comfortable, then they can add it to their practice once they get comfortable with it. And that's what I did, was baby steps. And then once I got comfortable and patients were, because dry eye disease is great for your practice. It's an out-of-pocket model. It's great. And for doctors looking for additional revenue, this is something where it offsets managed care. It builds patient retention, keeps patients coming back, because a lot of doctors say, patients, I have dry eye. They're like, oh, just go get some artificial tears at CVS. And you're really harming yourself in the long run. I found some data, and I was eye-opening. I saw some data. I forgot where I saw it. Artificial tear industry is $5 billion industry. So I was like, doctor, optometrists should have had this from the beginning. Like, it's just patients go and self-prescribe. Prescribe to them what they need, exactly what they need specific to them. Just like you would do with glasses, contacts, same thing with medical models with dry eye, cataracts, macular degeneration. Prescribe what they need. Tell them why it's different than others. So they continue to come back, because you don't want to be a commodity, right? I mean, you don't want them to think that they can just go self-prescribe and go to the CVS aisle.
Well,
and dry
most
eye
importantly,
is a great avenue.
Yes, you don't want to mistreat your patient. And, this is a lightning rod statement, but it's true. And you're going to wonder why I'm bringing my wife, the cancer survivor, into this discussion. But had she gone to a doctor who said, we're just going to put you on morphine and kept you comfortable, obviously we'd have gone someplace else for a second opinion. Putting patients on artificial tears, it's not going to result in their death, but what it's doing, obviously, it's covering up the symptoms as the disease continues to progress. And at some point in their lives, when they have no meibomian gland function left at all, they're going to be constantly dropping themselves with the artificial tears in order to retain some semblance of comfort and vision. Because we both know that, while we were taught that the cornea is the primary refractive surface, it's actually the tear film. So they don't see well, they feel like crap. And, our mantra is see better, feel better, and look better.
Yeah, I mean, and now's the time to get involved, right? A lot of dry eye now from masks, a lot of from computers. I'm seeing a lot of dry eye even in digital eye strain from kids. So it's a great opportunity to really get in and just ask a few questions. Doesn't take a lot from the exam, and even just the treatment options and the explanations don't take a lot. Once you get comfortable with your dry eyes procedures and follow-ups, when you have whatever your schedule's like, whatever you want it to be, you prescribe, they come back, you follow up, you already know. And if it doesn't work, you have the next step. So it's something that you just get comfortable with as you keep going. And the fact that you treat it and patients become so happy that you help them and they're not having this discomfort is a patient for life. I can't agree with you more. I've seen it in my practice, and it has grown tremendously. And started to brand it as the Dry Eye Center of Rhode Island, and starting to get new patients from Google to come in, that other doctors just say, hey, just use some artificial tears and just do some warm compresses at the house, and we'll see you in a year.
Yeah, take 2 aspirin and call me in the morning.
Yeah, basically telling them politely, like, just leave me alone. Where I'll say, hey, tell me what you got. If you're not happy, call me up. We'll do another appointment. We'll see what the next steps are. But it's good to do these steps. And patients, when you provide that and you have a dialogue, and they know that you care and that you're looking to help relieve symptoms, they're super happy. So just having something like this, like Nulids in their practice, where they say the last doctor didn't give me this and this is helping, you look like an expert. You look like a rock star.
Absolutely. Next month, in the July issue of Optometric Management, we'll have a piece in there, and it has quotes from 3 doctors. 2 of the 3 are very famous in dry eye, Laura Perriman and Ahmed Fahmy. And the lady in the middle, she will be famous at one point, but she's quite young. And she started work for another optometrist when she came out of school. And I asked her, when I interviewed her, I said, so what tools did you have available? She said, I had a slit lamp and a muscle lamp and my thumb. And yet she was one of the highest dispensers of Nulids, because with that slit lamp, you can see how many meibomian glands are functioning. With that muscle lamp, you can roll down and take a look and retroilluminate and see what the meibomian glands look like. And with your brain, you just ask a few questions. How many times a day are you using drops? Does your vision fluctuate? Are your eyes tired? And quite literally, with that limited piece of equipment and access to something like Nulids, you can help more than 8 out of 10 of your dry eye patients feel much better fast.
Yeah. Yeah, this is a great way to introduce something into your practice. It's not a big cost. Patients see relief pretty quickly.
Yes.
There's not a lot of quick follow-ups. If you want it to be, there's other options. But why not have patients get the problem solved quickly and be happy with you? I mean, it's the same thing as when I fit contacts. Right. If I'm going to fit a multifocal contact lens, I want to be successful right away. The first one, like first visit. They don't want to come back. They come to you as the expert. You want to get it. So you want to have good products to help you do that too, right? So this is something I think a lot of docs can implement. And I want to thank you so much, Robert, for coming on to the Facebook Live event and introducing everyone to Nulids. Hopefully, if anyone wants to, have it in their practice, I'll put a link at the bottom of this, and you can register. And it's a great way to get started in your practice, whether it's corporate, private, or even as an employed doc in a setting, they can kind of set it up for their own practice for the head doctor. So
absolutely.
Thank you so much.
Well, Dr. Sampalis, it was absolutely my pleasure and my honor to be here. I love telling our story because it's helping your patients and it's helping your practice.
Thank you so much for joining us.
Take care now. Bye.